In this section, we'll deal with the natural history and prognostic factors on histology. So we start with normal mucosa. You develop an adenoma, which enlarges in size and then starts to invade. It will then invade into the bowel wall and off to other areas. Now, that's the adenoma-carcinoma sequence, but you can also generate hyperplastic polyps from normal mucosa and serrated lesions, which give rise possibly to serrated carcinomas. The exact relationship between the hyperplastic polyp and the serrated lesion is less understood, but it's likely that some hyperplastic polyps will develop into serrated lesions and may go on to serrated carcinomas. Here we have a slide of the further progression of bowel cancer with our local invasion through the wall and spread off to lymph nodes, and then, if the patient is unlucky enough, spread off to the liver, either by a few isolated liver metastases which might be resectable, or, as you see here, massive invasion of the liver, which can only be dealt with palliatively. So, when we're decision making about prognosis and potentially trying to predict response to therapy, these are the factors that are most important. Clearly the stage is paramount, but the grade is prognostic, so if it's poorly differentiated, you have a worse outcome. The amount of stroma that you have within the tumour. High stromal content tumours have a worse outcome. The pattern of invasiveness, if they're round and pushing, the tumours do better than if they are irregular and infiltrating. If you have peritoneal involvement or lymphatic and vascular invasion or neural invasion, then they again have a worse prognosis. If the tumour is perforated, that is a very poor prognostic sign. Proliferation has been reported by some to be prognostic. The host factors are increasingly important. The immune response against the tumour, so if there are a large number of lymphocytes surrounding that tumour, then the patients have a better prognosis. And the number of lymph nodes that are found within the specimen. The higher the number of lymph nodes, the better the prognosis. Treatment factors, certainly in rectal cancer, we can assess the response to treatment, and now as we start to give chemotherapy to colon cancer patients, this also becomes important. And then we need to assess the completeness of removal and the plane of surgical removal as important factors. Molecular factors can be important. Mutations can determine therapy. So if you are wild type for Kirsten Raz, then you may benefit if you have metastatic disease from anti-epidermal growth factor receptor inhibitors. If you're deficient mismatch repair, then you have a better prognosis and a higher rate of metachronous cancers. Some people have suggested that you might even have a worse response to chemotherapy, but this is not overwhelming evidence at the moment. And then people have suggested RNA profiles are important, but at the moment they, in my opinion, are unproven. So these are a range of prognostic factors that you can examine to try and predict prognosis most effectively. So when a pathologist is reporting, they should be using a pro forma so that we capture all of the pieces of information that are necessary. If you don't use a pro forma, it is very common to forget, and therefore pieces of information are missing. And you should be reporting against your national guidelines. Each country has its own national guidelines, and if you don't have them, then you should be looking at others that are available and adopting them. And in the UK, we have guidelines for major resections and local excisions. These are the Royal College of Pathologists minimum data set, currently using TNM5. This is up on its website. Or you can use the US guidelines, which are using TNM7, should you wish to, and they're also up on their own websites. These are the current United Kingdom ones, which have just been updated, and they are all on a single page to try and make it as simple as possible. This one is for the resection specimens, and this one is a different one for local excision specimens, which are increasing in frequency both in rectal and in colon cancer. So the most important thing we do is we stage tumours, and here we have TNM staging, which is tumour, nodes and metastasis, and here are the T stage. So T1 is tumour invading into the submucosa, that is below the muscularis mucosae here. T2, tumour is invading into the muscularis propria, these two thick bands of pink muscle. T3 is through the muscularis propria and out into the subserosa. And then T4 is when the tumour has penetrated the peritoneal surface, or if it's across the peritoneal surface or a fascia going into another organ. Node status is important. N0 is if you have no nodes involved. N1 is if you have 1 to 3 lymph nodes involved. N2 is if you have 4+ lymph nodes involved. And then the metastasis stage, stage 4, will be M1, distant metastases, and here is another liver with extensive liver metastases, and here is the histology showing the liver, the adenocarcinoma growing in the liver here, and here is a liver biopsy showing adenocarcinoma present in this part and normal liver in this part. Now we use TNM5 in the United Kingdom, and here is TNM5 going from PT0, where there's no evidence of primary tumour, to PT1, 2, 3 and 4. And here are the regional lymph nodes, and here are the distant metastases. Now in the United States, they use TNM7. The things that are different within this is that they've reversed the T4A and T4B, potentially leading to confusion with TNM6, 5 and 4. They have increased the number of subdivisions of the lymph nodes here, but we have this N1C category, which is different to TNM5. And then we have metastasis subdivided into M1A and M1B here. So we don't use TNM7 in the United Kingdom because of reproducibility issues. And the main problem here is tumour deposits. Now, tumour deposits are defined as stage N1C in TNM7, and this is stage 3, and therefore the patients would qualify for adjuvant chemotherapy. The problem with M1C is that in TNM6 it was defined as either round or irregular, and because of the non-reproducibility of this, we've ended up that the TNM group have suggested that we don't have a specific definition and that the pathologists should decide what they think is a nodal deposit and what they don't think is a nodal deposit. In our opinion, that is unacceptable and leads to stage migration, and therefore we have not adopted TNM7 because of this. We believe that serial changes in TNM increases the confusion and increases the variation in practice. And more importantly, it affects all ongoing treatments. If you keep changing your stage such that people will move in and out of stage 3, they may or may not get adjuvant therapy. If you run clinical trials over the boundary of a change between TNM classifications, then it will disrupt the staging within the clinical trial. It will also disrupt population data sets and long-term studies, because you'll be having different distributions of cancers in different stages because of these artificial changes. And you lose the use of your historical control groups to define whether you're improving outcomes. And we see this within our registries, and it makes it very complex to compare large data sets over large periods of time, which we must do to ascertain whether we're improving outcomes. Now, there's a difference between stage in colon and rectal cancer. So here are the T and N stages of 10,000 patients nearly of colon and rectum, showing that actually the rectum has more PT1, PT2 cancers than colon. So on average, rectal cancers are an earlier stage than colon cancers. Colon cancer has more PT4 than rectum because of the extensive peritoneal surface and the close proximity of that peritoneal surface to the muscular wall. And therefore we see increased invasion through the peritoneum within the colon than we do over the rectum. And on average, colon cancers are actually larger than the rectal cancers, and the mean tumour diameter in this population was 5.1 centimetres versus 4.2 centimetres in the rectum. So colon cancers tend to be larger, they tend to be PT4 and less PT1, PT2. Now, screening increases early stage disease, but it does that both in rectum and in colon, so it affects both tumour sites, and it also reduces late stage disease both in rectum and colon. So screening will change the population and that you're dealing with and the stage of those tumours. But bear in mind that colon cancers are larger with more PT4s than rectal cancers. In this diagram we show the PT stage in colon cancers, showing PT1s have a better prognosis than PT2s, than PT3s, and PT4s have a relatively poor survival. So T stage is an important prognostic factor. Turning to lymph nodes, we'll deal with a number of issues here. Firstly, the definition of a lymph node, the morphological definition, and then how things have been changing in TNM. The factors influencing the number of lymph nodes found, which are multiple and complex, and then we'll deal a little bit with the status of isolated tumour cells, micrometastases, and tumour deposits. So firstly, what is a lymph node? Now these are lymphoid collections of various sizes. Here we are at 0.5 millimetres, here at 1 millimetre, here at 2, and here at 3 millimetres. So I would not consider this 0.5 millimetre lymphoid collection to be a lymph node. I would call this a lymphoid aggregate because there is no capsule to this lesion and no structure to it. At 1 millimetre, we start to see a round structure with a subcapsular sinus, so it's got an organised structure to it, and I would consider both of these as small lymph nodes. And then at 2 millimetres, it becomes much easier to see the subcapsular sinus and the structure of this lymph node, and then at 3 millimetres, it's absolutely no problem. So here, this is a lymphoid aggregate, but these have lymphoid structure to them, and I would consider and count them as lymph nodes. Now, the TNM changes involved, the TNM changes of involved lymph nodes affected the stage. And in TNM4, we only dealt with anatomical lymph nodes. In TNM5, we dealt with anatomical lymph nodes. And if you had tumour deposits greater than 3 millimetres, it was considered to be an involved lymph node. The evidence base for this turned out not to be very good. TNM6, we had the anatomical lymph nodes, and then round tumour deposits were considered as N1 or N2. They were included in the lymph node count. Now these were non-reproducible. And then in TNM7, we had the anatomical lymph nodes, and then we had any other lesions that were thought by the reporting pathologist to be a lymph node deposit were called N1C. And in this diagram, you can see how the individual structures that we see here changed their stages dependent upon whether they were staged under TNM 4, 5, 6 or 7. So TNM 6 and 7 introduced variability into TNM, and that's why we stayed on TNM 5 in the United Kingdom, even though this 3 millimetre rule was not proven to be very good. We didn't want to move to the non-reproducibility of TNM 6 and TNM 7 in terms of this category of N1C. Now, what factors affect nodal yield? This is a study which we undertook looking at a range of factors that are shown there with the odds ratio. But what it says is that the number of lymph nodes increases with younger age, female sex, larger tumours, later stage. With an increasing number of positive lymph nodes, you'll have an increase in the overall lymph node count. If you're a GI pathologist dissecting a specimen rather than a general pathologist, or if you're a specialist surgeon rather than a general surgeon. And also, if you've had no preoperative therapy, you'll find a higher number of lymph nodes than if you have had preoperative therapy. So there's a wide number of factors that affect the lymph node yield. For the pathologist, increasing the lymph node yield is related to the interest, whether they've been educated in this area, whether they are undergoing audit, and feedback. That will increase the numbers. And they can increase their numbers by using different node recovery methods. People have suggested fresh dissection. I find thin slicing and palpation to be very good, but you can use GEWF fixation to turn the lymph nodes white, or you can do ex vivo methylene blue arterial injection to turn the lymph nodes blue, and these should increase the number of lymph nodes found. The surgeon can increase their node yields by increasing the amount of tissue removed and by the intactness of the resection. In this slide you can see that we can use fat clearance. You can get large numbers of lymph nodes out with careful hand dissection, and here is a case from Russia where over 100 lymph nodes were removed. This is methylene blue injection. Here is the original paper, but these specimens are from Denmark. This is the GEWF solution description, which turns the lymph nodes white and increase the average lymph node from 10 to 17. And here the use of methylene blue injection showed that they increased the number of lymph nodes from 20 to 46 in a hospital where complete mesocolic excision was being performed, showing that it is possible to get a very large number of lymph nodes from specimens if you have the right surgeon, the right pathologist, and the right techniques. So the extent and quality of the surgery increases the node yields, and you can see here poor surgery, relatively little tissue removed, and excellent surgery, and sampling these as a pathologist will be likely to yield many more lymph nodes than sampling these. Node involvement is a strong prognostic factor, with N0 cases with no nodal involvement doing much better than N1 or N2. Now, the size of deposits is important. Under TNM, if you have just isolated tumour cells, as shown here, just the occasional little clump of tumour cells, then that would still be classified as PN0. If the metastasis is small, that's less than 0.2 of a millimetre, it would still be classified as PN0. Tumour deposits are under TNM7 dependent upon the individual pathologist, or if you're under TNM5 would be anything that is larger than 3 millimetres. Now, when you look at the size of uninvolved lymph nodes, it has this distribution here. So in this study, we looked at 112 cases, 1,700 lymph nodes measured, and looking at here the area, but we also measured the width and length of these nodes. But here we have the lymph node area, and you can see that there is a normal distribution of the normal lymph nodes, and then here we have the metastatic lymph nodes. And immediately you can see that the very large lymph nodes are mainly metastatic. But actually, there's a lot of metastatic lymph nodes that are within the normal distribution of normal lymph nodes. And these will be missed by the radiologists, whereas the enlarged lymph nodes will be found. So it's likely that radiologists will miss some metastatic deposits. And we know that in colon cancer, lymph node staging is not very accurate on CT. Now, the number of lymph nodes you have in the specimen is also prognostic. And this is prognostic not only in stage 1, as we see here, but it increases in its prognostic value in stage 2 with a very wide distribution of outcomes dependent upon the number of lymph nodes you find in the specimen. And this also holds true for all the lymph nodes present within stage 3. And in stage 3, the number of negative lymph nodes is also prognostic. So having a large number of lymph nodes in your specimen is important and will confer a better prognosis than if you have a small number of lymph nodes in your specimen. So your prognosis worsens for each positive node, but improves for each negative node. And therefore people have thought that you can use a thing called the lymph node ratio. Now, I personally think there's a problem with the lymph node ratio because the number of positive lymph nodes is assessing the tumour aggressiveness, so how metastatic is that tumour. And the number of negative lymph nodes is assessing the host response. And these are two different things. Now, the other thing to take into account is that the ratio will vary from site to site. So if you're a place that finds large numbers of lymph nodes, and if you're a hospital that finds small numbers of lymph nodes, then that lymph node ratio will be different from one hospital to the next. It will also be different in different countries. So it's reduced in Japan compared to Erlangen, because in Erlangen they take a much larger number of lymph nodes because they do a larger excision. So the lymph node ratio is affected by the factors leading to the variability in the number of lymph nodes found, which is, again, the extent of surgery, the quality of the pathologist. The other thing for a ratio is that the actual lines of the relationship of the number of lymph nodes to prognosis and the number of positive lymph nodes to a poorer outcome has to be exactly equivalent in order to get a ratio that is consistent throughout the number of positive lymph nodes or the number of lymph nodes that you find. And I don't think that is the case. Just as an example of what happens with lymph node number, here is 20,488 cases taken from Proforma's Northern Yorkshire region, which has a population of 5 million. And what we have here is the year, and then we have the average number of lymph nodes found. And as you can see, pathologists have been getting better from 1995, when we had an average of 7 lymph nodes a case, to 2010, when we have an average of 18 lymph nodes per case. And look what's happened to the lymph node ratio. So here the lymph node ratio was 33%, and now with the increased number of lymph nodes, it's dropped down to 15.8%. The thing that's changed is the number of lymph nodes being retrieved. It's not any change in the biology of these tumours, and it's not the effect of the introduction of screening, because there was relatively little screening in this time down here. So I don't think that lymph node ratio is a very valid method of using the total number of lymph nodes found and the number of positive lymph nodes found. You're much better describing them as individual features. Now, people are investigating sentinel lymph nodes. These can either be identified at operation or ex vivo. What possible value could they have? Well, if they change the operation, if you're looking for sentinel nodes and positive sentinel nodes at operation, then you could actually change the operation from a complete mesocolic excision, a D2, to a complete mesocolic excision with central vascular ligation, to a D3, therefore going after those higher lymph nodes and therefore potentially removing any metastatic disease that was present in those higher lymph nodes. If you do it ex vivo, then you're working on the basis that if you increase the examination of this node, which is going to contain the tumour deposit, if any of them are going to, either by intense histology, cutting serial sections, or immunohistochemistry or molecular analyses, then you would potentially be trying to identify more stage 3 cases by doing this. Now, that is all very well, increasing the number of stage 3 cases, but what we still don't know is whether if you have these cases with occult stage 3 that you found by this intensive examination, whether actually they do derive any clinical benefit from chemotherapy, and that would remain to be proven. So I think that at the moment sentinel lymph nodes are an area of interest, but they remain unproven in colonic cancer as to having a clinical value. So when you do your cross-sections, you should also always have a careful macroscopic examination. You need to look at the distance of extramural spread. You need to look for the presence of extramural vascular invasion. You can sometimes see neural invasion. You can definitely see suspicious areas of peritoneal involvement, and certainly perforation. Also look and sample the tumour deposits and assess the retroperitoneal margin. Now, extramural spread is complicated. It was first introduced in the 3rd edition of TNM, and then in the 4th edition of TNM 7 supplement, they changed the rectum to PT3A less than 5 millimeters spread, PT3B greater than 5 millimeters spread, and split off the colon to PT3A less than 5 millimeters, PT3B 5 to 15 millimeters, and then PT3C 15 millimeters plus. So the colon has a different TNM7 staging for extramural spread than the rectum. Here are some examples of extramural spread showing the tumour extending out for variable distances out into the mesocolic fatty tissue. And this is a prognostic feature, and the further out it goes, the worse the prognosis for the patient. Here you can see the distance of extramural spread in colon cancer from the Yorkshire dataset, showing that the prognosis declines as the tumour extends out to a greater distance. A very important prognostic factor is extramural vascular invasion. This can sometimes be seen on CT if it's extensive. As pathologists, we underreport it. You can improve this by looking carefully at the macroscopic cross-sections for thin fingers of tumour extending through and outside the bowel wall, and you should have a high suspicion of this on your histology. You should be able to find it in 35 to 50% of all cases if you look hard enough, and you can use special stains, and that increases the frequency of finding extramural vascular invasion. Here we can see extramural vascular invasion both in the macroscopic pictures and examples within the microscopic pictures of large vessel and small vessel extramural vascular invasion. And here we have the impact of extramural vascular invasion on colonic cancer survivals, and it has a major impact, dropping the survival substantially. So therefore it's well worthwhile putting in the effort to identify it. Neural invasion also reduces the prognosis, as shown in these studies here, and can be seen on histology relatively easily, looking for the presence of tumour glands within neural structures. And these can sometimes be long bands like this, or you can cross-section those nerves and they look like small roundish deposits. But if you look carefully, you'll see within it that there are embedded nerves. Peritoneal involvement is a very important prognostic factor. You start by looking carefully on the macroscopic slices, you sample the suspicious areas, and on histology, the tumour must penetrate the peritoneal surface to be called positive, so positive for peritoneal invasion. You can see the suspicious areas both by looking at the macroscopic specimens as shown with the arrows, these areas that you must sample, but also on cross-sectional slices. And here is some histology showing the tumour having breached the serosa here, here, just breached the serosa here. So all of these are peritoneal involvement, but in this situation we have the peritoneal surface intact, tumour just underneath it, but it's not peritoneal involvement. Again, we have complexities with TNM7. In TNM7, T4A penetrates the surface of the visceral peritoneum. T4B directly invades or is histologically adherent to other organs or structures, as shown in the diagram. But in versions 4, 5 and 6 of TNM, it's the other way round. So please don't get confused by T4A and T4B, and sometimes it's optimal to actually refer to it by the fact that this is peritoneal involvement or this is involvement of the other structures that are adjacent. Here are some examples of the prognostic importance of peritoneal invasion. This is one series of 410 cases where they looked at the types of peritoneal involvement and showed that only tumour at the surface and tumour cells free with adjacent ulceration were the important types of spread. And here is another series by the same authors showing again that ulceration of the surface and tumour on the surface was the important factor. With the cancer-specific survivals of their absent or inflammatory reactions much higher than if it was present or ulcerated. This is the data from our population in Yorkshire. Here, nearly 6,000 cases, and you can see that if you had peritoneal involvement, your prognosis was much worse than if you did not have it, and you can see the overall survival was significantly different. In this picture you can see colonic perforations. These are not as frequent as in the low rectum, but they do exist and they carry a poor prognosis. So in our stage 2 cases in Yorkshire, if it was present, tumour perforation dropped the survival by about 30%. And here, tumour perforation in this other study, again in stage 2, dropped the prognosis substantially, as well as adjacent organ involvement. Tumour deposits have been discussed a lot recently. We're critical of tumour deposits, as can be seen in this article, because they are made up of a number of different methods of tumour spread. So vascular invasion, perineural invasion, lymphatic invasion, or they can be destroyed nodes. And we prefer to be able to describe the actual mode of invasion, if at all possible, because we believe that that carries added information. And it also depends how hard you look for them. So in this review, we looked at a number of papers, and you can see that the incidence of tumour deposits varies from 4.5 to 45%. And so the actual importance of tumour deposits in the literature is probably not very well determined. Here we have the number of studies, and both in colon and in rectum here we can see that actually the presence of tumour deposits has a worse prognosis, and overall is a hazard ratio of 1.96. But if you then look at the specific modes of spread, you can see that perineural invasion is reported as having hazard ratios between 1.5 and 2.9. Extramural vascular invasion, 1.8. Lymphovascular invasion, 1.6 to 2.8. Extracapsular spread in lymph nodes or lymph node metastases here, and invasion into other organs. But it's got a very similar hazard ratio to these other ones, but we feel that defining the types of spread that you've got in the mesocolon is important because it might end up with different patterns of metastatic spread, and therefore defining whether it's extramural vascular invasion or perineural invasion might be important. Turning to incomplete excision at the retroperitoneal margin, there aren't very many good studies. We know that it's very important in the rectum and low rectal cancer, and it's crucial that we get complete excisions in this plane. We also know it occurs in the right side of the colon, and here we have the retroperitoneal area on the back of the ascending colon and cecum, outlined here and then inked. And here we have a tumour which is coming out to that retroperitoneal margin. We usually see this in very advanced disease. It's around about 12% of the population when there isn't extensive screening, but we have less evidence for its importance. In Bateman and Warren's study, they found that 11% of all right-sided resections had involvement of that margin, but they didn't have any local recurrence data. In the MRC Classic trial, we had 140 right hemicolectomies, 17 of which had involvement of that retroperitoneal margin. So that was 12%. And when we look at the local recurrence data, or we look at the survival data, we didn't see any significant difference in outcomes between these cases. And this is probably due to the fact that to get out to that retroperitoneal surface, you're probably already out to the peritoneal surface, and it's already a PT4 with a worse outcome. So we feel that it isn't having the same critical impact on outcome in the right side of the colon as it does in the rectum. So tumour grade describes the aggressiveness of the tumour, and that's how quickly it's likely to progress by local spread and systemic metastasis. It's based upon how similar the appearances are of the tumour to the normal mucosa in terms of its cytological and architectural appearances. Now, different classifications divided up into 2, 3 or 4 divisions. Now, within the United Kingdom, we only describe 2 categories of poor and others. And this helps us to increase the reproducibility. And when you're making management decisions, frequently you only have 2 choices as to whether to give treatment or not to give treatment. And therefore, only having 2 grades makes the management of these patients easier, because for the poorly differentiated cancers, you'll tend to be more aggressive than you would for the well or moderately differentiated cancers. So a well-differentiated tumour have well-formed glands. Poorly differentiated tumours have little or no glandular formation. The cytology of the cells in well-differentiated will be basally aligned with little but not marked cellular atypia, whereas in poorly differentiated tumours you'll have marked cellular atypia, easily visible mitoses and necrosis. One cautionary note about grading is that beware of poor or mucoid differentiation, because many deficient mismatch repair cancers, which have a lower metastatic rate than non-mismatch repair deficient cancers, may be poorly differentiated or have mucoid differentiation. So it's recommended in the WHO book that you should check the mismatch repair status of such tumours before you ascribe poor differentiation to them. For a better description of grading, go to the WHO classification of colorectal cancers as shown here and use their description. So in the Royal College of Pathologists, we use poor and other. The classical grading differentiation is well, moderate and poor, and WHO use 4. I personally feel that this has relatively little value because we really only have 2 decisions to make, to treat or not to treat, and therefore having 4 grades is less helpful and also increases the inter-observer and intra-observer variation in grading. Here are examples of a well-differentiated tumour here, showing the cytology of the individual tumour cells is relatively bland, and they're basally aligned on the basement membrane. Whereas with the moderately differentiated, we have much less regularity of the glands, and we have the nuclei which are stratifying all the way through the epithelium here. And then when we move on to poorly differentiated tumours, you see a lack of glandular formation, and you can see the very bizarre cytology and the failure to form glands. Now, in colon cancer, we may be moving to apply some of the principles that we're using in rectal cancer and starting to give people with colon cancer preoperative treatment with chemotherapy. Currently, there is ongoing the Foxtrot trial where patients are being given 6 weeks of preoperative chemotherapy. And we're looking at the effect of the 6 weeks of chemotherapy on the tumours that are removed from these patients. And what we see is that the tumour responses can be marked. So in the phase 2 trial, where 50 patients were untreated and went straight to surgery, and 99 patients went for preoperative treatment and then surgery, we could see some marked effects. So in this case, you see there's an area of tumour that is relatively untouched and an area of tumour that's completely disappeared. In this case, we have islands of tumour cells, residual tumour cells left, as you might see after radiochemotherapy, and here is some intact extramural vascular invasion. Here we have mucoid change, signifying extensive cell death with just mucin pools left behind. And here we have a tumour where there's been extensive cell death with just small lumps of tumour present. Here is a complete response after only 6 weeks of chemotherapy, and in this case we just had one isolated gland left behind that could be found. So even on just 6 weeks of chemotherapy, some of these cancers are exquisitely sensitive, and you may be doing regression grading on colon cancers in the future, as well as rectal cancers. So in summary of the prognostic factors, cancer surgery needs to remove the cancer and its regional spread. The area removed and the intactness of the specimen varies between surgeons, and we want to make this as consistent as possible. Mesocolic excision and central vascular ligation should be considered in nearly all cases. Photographs help to demonstrate the quality of surgery and spread of the tumour. The dissection techniques are important, and spread into the mesocolon can be by direct invasion, nodes, extramural vascular invasion, neural or tumour deposits. Thank you.